good morning. I'm actually connecting from Pittsburgh today. It's the Pittsburgh Vascular Symposium, so it's much easier for me to be with you at this time of the day. It's really a pleasure and an honor again to giving grand rounds at your really large department. I was looking at the number of faculty you have, and it's really impressive. So today I will be discussing on pulmonary embolism, and I believe that whoever is treating deep venous thrombosis should also be aware on the contemporary management of pulmonary embolism. And as you will realize during my talk, we have so many new procedures now available and devices. It's worth getting familiar with these devices, particularly if you have an interest in managing DVT. The concept and the type of devices we're using are very similar. And I understand not many vascular surgeons are jumping into this field, and interventional cardiologists or interventional radiologists have the main bulk of these procedures nationwide. But let's see where we stand today. So the reality is that pulmonary embolism has been increasing over the past 10-20 years. It has been increasing because of a higher number of procedures, because of an aging population, and because we have better technology to diagnose PEs that we could not diagnose in the past. It's the most common preventable cause of in-hospital death. 10% of these patients will die in 3 months. 50% will have some kind of exercise limitation at 1 year. And despite these numbers, in comparison with ischemic heart disease or stroke, pulmonary embolism does not enjoy a robust clinical trial evidence to dictate appropriate therapeutic strategies. Now, when it comes to diagnosis, whenever we suspect a pulmonary embolism, how we're going to move on depends on the stability of the patient. So if the patient is stable and you have a low clinical probability of pulmonary embolism, you can just ask for D-dimers. And if they're positive, then you can order a CT scan. If the D-dimers are negative, then pulmonary embolism is out of the question. If the patient is unstable, then you have to order an urgent thoracic echocardiogram, and then depending on the positive or negative findings, move forward. So in simple words, patients with high clinical probability for pulmonary embolism, patients who have chest or back pain or syncope, they should get a CT scan or an echocardiogram. And you can see nice images here. You can see the thrombus at the main pulmonary arteries. You can see at the CT scan the dilatation of the right ventricle against the left ventricle. That is a sign that the right heart is stressed, that there is a high pulmonary pressure. You can see here the image at the echocardiogram. Again, you can see the RV being dilated versus the LV being restricted. The pulmonary arteriogram will only be done if you decide to intervene with one of the novel intravascular procedures. Now, when discussing about management of pulmonary embolism, we really need to know the classification of pulmonary embolism. We used to call it massive or submassive based on the amount of thrombus in the pulmonary arteries. But in today's terminology, we should be saying low risk, intermediate risk, or high risk. Low risk is when you have no right ventricular dysfunction, no positive biomarkers. Intermediate risk when you have echocardiographic RV strain or positive biomarkers, and that is troponin or BNP. When you have, in addition, hypotension or need for vasopressors, this is when you have the high-risk pulmonary embolism. And you can see how mortality increases based on this classification. Anticoagulation is, of course, the standard of care, but as the severity increases, we need to escalate treatment towards systemic thrombolytics, catheter thrombolytics, aspiration, or surgical thrombectomy. And of course, the decision is not that easy because the evidence is weak, the recommendations are low level, high expertise is required, and high risks are involved. You understand that the pulmonary arteries are really big vessels, so there is a lot of clot sitting in there. So what happens if we don't remove this clot? well, mortality is the main concern, but there is also a risk of long-term pulmonary hypertension. Let's move back a little bit in time, almost 10 years ago. And we know since then, that's a large meta-analysis, that systemic thrombolysis against anticoagulation is associated with a 47% mortality risk reduction, but this comes at a high major bleeding rate that is almost 10%, with 1.5% risk of stroke. On the other side, more than 60% of the patients will actually have a contraindication for systemic thrombolytics. So at the same year, we got the first randomized trial with catheter interventions, and we found out that in intermediate risk pulmonary embolism, ECOS, that's the ultrasound-assisted catheter thrombolysis, is superior to heparin alone in reversing RV dysfunction at 24 hours without an increase in bleeding events. In simple words, with catheter thrombolysis, you can get the benefits of systemic thrombolysis without having the adverse event of bleeding. And there is also some evidence on the effect of thrombolytics in alleviating the long-term PE sequelae. So since 2014, we've seen a tremendous increase in literature and publications relevant to pulmonary embolism and catheter intervention. And we have several trials that have already been completed or are ongoing on catheter thrombolytic devices, on aspiration thrombectomy devices, and so on. And they all show some kind of safety and efficacy. We already have the Peerless trial, that's a head-to-head comparison between catheter thrombolytics and aspiration thrombectomy. But there is an elephant now here in the room, and the elephant is that all devices do not have, that are running these trials, do not have a comparator arm that is anticoagulation. And this is very well described in this paper from Suresh Vedham. Any catheter-based therapy should not be called effective because absent a randomized comparison with a non-intervened control group, there is no way to know if patient changes over time were not simply to the use of anticoagulation. The HI-PYTHO is a trial right now enrolling patients. They are comparing ECOS, that's ultrasound thrombolysis, versus anticoagulation for intermediate high-risk patients. This is an industry trial, but the trial that is even more important is the PE track trial. It's NIH funded and it's actively enrolling, comparing patients with intermediate risk pulmonary embolism receiving anticoagulation against those receiving any catheter-based therapy. The results are going to be available approximately 3 years from now. So let's see when an endovascular procedure comes into play and how we should manage pulmonary embolism. Again, based on the classification that we discussed, if you have a low risk or intermediate low risk pulmonary embolism, then you will only consider anticoagulation. But if you have an intermediate high pulmonary embolism, and this is positive biomarkers and positive echocardiogram, then you should consider an intervention. If the patient is low bleeding risk, you can do catheter thrombolytics. If the patient is higher bleeding risk, you can consider aspiration thrombectomy. Now, talking about intermediate high risk and how you select the patients, well, it's not only RV dysfunction. You can also look at the heart rate. It needs to be more than 110. Systolic blood pressure, it needs to be soft, below 110. And you need to have a patient that has inability to speak, difficulty to move from the chair, increasing oxygen requirements, and so on, to pull the trigger for an intervention. Now, for the high-risk patients, those who are hypotensive, you don't really have much time. So to rush things, you will either give systemic thrombolytics if the bleeding risk is low, but if the bleeding risk is high, then you can only consider aspiration thrombectomy. But now with contemporary devices available, why not do aspiration thrombectomy for everyone that is eligible for some kind of advanced therapy? So this is the room, a hybrid room that we're performing these procedures at UPMC. We will typically access the internal jugular vein or the common femoral vein. cannulate the pulmonary arteries, perform an arteriogram, and then decide on what technique we want to use. And we have thrombolytic techniques, standard, or that's the standard catheter, or ultrasound assisted, or the vascular catheter that has multiple wires dripping TPA. These are smaller and typically cheaper devices compared to aspiration thrombectomy devices. The lytics have the benefit that can reach the remote PA branches, there where no thrombectomy device can go. They are generally friendly, crossing the tricuspid valve, and we have the majority of evidence. But you have to wait several hours till the patient actually gets better, at least 4 to 6 hours. There are still major bleeding events and frequent contraindications. This is how the procedure is done. You introduce the multi-site hole catheter inside the thrombus, and you drip TPA 1 milligram per hour. ECOS, that's the ultrasound-assisted thrombolysis. It has been shown in vitro that it can increase thrombus clearance by 50%. Technically, it's very similar to the standard multi-site hole catheter, like the Unifuse or the Craig McNamara. Now, we ran a randomized trial in Pittsburgh, and we compared ultrasound-assisted thrombolysis against standard catheter thrombolysis, and we didn't find a real difference in thrombus reduction within 48 hours. However, we didn't use the low dose and fast track protocol that the ECOS is now recommending, like 4 hours of thrombolytics. Our average time of thrombolysis was 10 to 12 hours. Another catheter for thrombolytics, that's the vascular catheter. It's now on trial. That's the PE rescue trial. You can see it has multiple wires dripping TPA, so that's potentially more effective and faster in reducing the thrombus burden in the pulmonary arteries. But the reality is the majority of the cases we're doing today are done with aspiration thrombectomy devices. The clot is macerated and aspirated. And the main representatives of this category is the FlowTriever device, it's the AngioVac AlphaVac, and the Penumbra device. These have minimal bleeding risks since there are no lytics involved, no contraindications, and you can get quick reperfusion. But the problem here is that these are large devices, they are more expensive devices, they are difficult to navigate through the heart. There is always a risk of injury. There is a risk of decompensation, as these are bulky devices that you are advancing through the tricuspid valve, that you can actually obstruct the outflow of the right ventricle. And you can still lose blood because you're not only aspirating thrombus, you're also aspirating blood. This is the Penumbra device, the CAT-12, the intelligent aspiration, as they call it, because it has this addition, the lightning part that will differentiate thrombus from blood. It will stop aspirating when it detects blood, and it will initiate aspiration when it detects thrombus. So this is a case I did a few years back. That's with the Penumbra CAT-8 device. You can see my catheter coming from the right IJ into the left pulmonary artery. Look on the left of my screen. You cannot even see the left pulmonary artery. It's full of thrombus. And after the aspiration, you can see how nice the left lower pulmonary artery branches are now open, and you can see the thrombus that was removed with an immediate improvement on the table, with the heart rate dropping down to 80 from 115. FlowTriever, many people are familiar with the FlowTriever, no capital equipment required. You have an aspiration syringe and the FlowTriever sheath and the discs. 90% of times, you only have to do aspiration. When the thrombus is resistant in coming out, that is more chronic, you can use the FlowTriever discs. Here is a case I did a few months ago, and actually this was done in Athens, Greece. 72-year-old male with acute high intermediate risk pulmonary embolism. He received a systemic thrombolytics. He got better and went up to the ward, but a few hours later decompensated. So I have this patient now who has already received systemic thrombolytics. and is now decompensating. Heart rate 140, starting at the 85%, and the blood pressure 100/70. So here we are in the operating room. You can see my pigtail being in the left pulmonary artery. I measured the pressure that is really high, 92/45. I position my catheter in the left lower pulmonary artery. You can see the branches. I exchange to a stiff wire. I'm introducing the dry seal sheath. That's the 24 French sheath. And through the dry seal sheath, I'm advancing the flow trigger device. That's a 24 French catheter. And you can see how flexible the catheter is crossing the heart. That's over an Amplatz wire and going down into the left pulmonary artery. I can use the sheath if I want for an arteriogram, but what I'm actually now doing is aspiration with a syringe. Then I'm doing the same thing going from the right side. After I do a few aspirations on the left, again, continue aspiration. Now you can see here, there is another catheter going through the main catheter. So the outside catheter is the 24 French sheath. The inside one that goes deeper is the 16 French catheter that helps me reach into the deeper branches and remove more thrombus. And that's the final result with an immediate on-table improvement. Another device that we have using, that's the angiovac. It's a little complex because you have to use extracorporeal circulation, but now the AlphaVac device is actually handheld and you don't need extracorporeal circulation. And this is how it works. Again, it creates a vacuum that helps you aspirate the thrombus out. Very similar actually to the Inari concept. We have used it in the past. I haven't used AlphaVac yet, but the older device was very rigid, but really powerful in removing big pieces of clot. Now, some people ask me, what should I do? What's better, thrombolytic or non-thrombolytic? The reality is that they are complementary. If you mainly have distal thrombus, you should rather use thrombolytics. If you have proximal thrombus, big, bulky, you should rather use a thrombectomy device. Now, the procedures are not risk-free. I've seen all kinds of complications, systemic bleeds and strokes with catheter thrombolytics. I've seen cardiac and lung injuries with thrombectomy devices, and we are still losing blood even with aspiration thrombectomy. On the left of the screen, you can see a coronary sinus accidental cannulation. When the patient initiated thrombolytics, there was a cardiac tamponade, required open heart surgery. On the right of the screen, you can see the angiovac device. We had a very good result in removing thrombus. However, we had a tricuspid rupture and the patient required open heart surgery a few hours later. Now, there is a learning curve involved. This is our experience in Pittsburgh. 10 years ago, our failure rate was close to 16%. Now, our failure rate is down to 3% with zero major bleeding. So there is a technical learning curve. There is a patient selection learning curve. Now, the results are going to be a lot better if you create a pulmonary embolism response team. This is actually in the European guidelines now, a recommendation. And I will finish with this case just to show you how pulmonary embolism response teams work. This is a case we did a few years ago at UPMC. This is a 32-year-old African-American male. He has increasing shortness of breath over a 3-day period. He was initially given oral prednisone with no improvement. He is back at the primary care facility, and the chest CT now confirms bilateral pulmonary emboli and RV dilatation. The patient is transferred to UPMC Presbyterian on a 10-liter face mask, heart rate 100 to 140, systolic blood pressure relatively good, and a high troponin. So this is an acute submassive pulmonary embolism. The mortality risk is 3 to 15%. He's a young patient. You could do heparin alone. You could do systemic lytics, catheter thrombectomy, or even surgical thrombectomy. And then the question is, who do you call? Do you call pulmonary medicine, cardiac surgery, vascular surgery, interventional radiology? Who makes the decision? These are difficult questions to answer, and this is where a pulmonary embolism response team comes in. So we have a Perth team on call. Pulmonary medicine, vascular surgery, and cardiac surgery come together and decide catheter thrombolytics. So as the patient is rolled back to the interventional suite and receives light sedation, we get a sudden respiratory deterioration and a hypoxic cardiac arrest. So we have this patient converted into massive pulmonary embolism. We initiate CPR and push in 50 milligrams of TPA. The patient is intubated, and we have a return of the vital signs. The echocardiogram now shows severe right ventricular dysfunction and poor oxygenation. The ECMO team comes in, and the PER team decides to place an ECMO, a left femoral venous cannula and a right femoral arterial cannula. The patient is transferred to the ICU, and a CT scan now confirms a major RP hematoma. Remember, we gave thrombolytics to this patient systemically, and we had two percutaneous access with big cannulas, so no surprise we have a big RP hematoma. Anyhow, the patient remains on ECMO support for 2 days, and there is no improvement. He's not a candidate anymore for thrombolytics due to the major bleeding. He's too sick for surgical thrombectomy. So the PER team comes in, and we now decide to proceed with aspiration thrombectomy. Here's the patient on ECMO in the operating room. And we are accessing the IJ, getting into the right pulmonary artery, look at the high pressure and the high amount of thrombus. We used the flow retriever device and the flow retriever discs, removed these amounts of clot, and we had a pretty good response. Patient was weaned off ECMO the next day. He was found to be lupus anticoagulant positive and discharged 12 days later. So to conclude, catheter interventions are here to stay. Aspiration thrombectomy is definitely a game changer. You can get faster clot removal and faster RV function recovery. You can prevent RV decompensation. You may be able to prevent pulmonary hypertension. These are definitely not complication-free procedures, but complications may actually be less than those of systemic thrombolytics. Careful patient selection in high-volume centers with appropriate expertise within the PERT is essential for optimal outcomes. With that, I would like to thank you for your attention, and I would be happy to answer any questions if any.
That's a great talk. Thank you so much. I was coming from an emergency medicine background, and now being practicing veins for 14 years, have seen the combination and perhaps sadly how predominant pulmonary embolisms are, and perhaps how often they're missed. So this is really, really helpful. Thank you so much. Really, especially with the new classifications and perhaps how we can communicate to our colleagues that we're trying to consult to get the right treatment for the patient.
Absolutely, and we are actually involving the emergency room physicians in the PERT, so they are very well aware whenever a PE shows up, they will have to page the PERT. So there is a specific pager number that they need to call whenever there's a diagnosis of pulmonary embolism. And we also have VSI, artificial intelligence now installed in our hospital. So the minute a CT scan is done and a PE is captured, the PER team receives on their pager that there is a PE right now in the CT scanner. This is very helpful to streamline these patients faster towards the PERT and initiate either anticoagulation faster or consider a catheter intervention.
Is that AI system integrated with the?
Yes, it's integrated in the radiology department. Google it, VSI. That's how they call it, VSI.
How do you spell that?
VIZAI.
Thank you.
They're actually doing the same thing now for aortic aneurysms and multiple other pathologies to streamline these patients faster towards the right specialists.
Good to know. Thank you.
Well, you're
Does the
welcome.
European studies delineate how you form these pulmonary embolism teams? Like, what are the steps to take?
Well, this started 11 years ago at Mass General Hospital. This is where the PERT concept was created, and it was Ken Rosenfield, and the PERT consortium now happens every year, and it gives us all the updates on PERT teams and pulmonary embolism management. So all you have to do is just to find 2-3 people who are interested in pulmonary embolism. You typically need to have a pulmonologist or a critical care medicine. You need to have an interventionalist. Whoever really has interest, it will be either a vascular surgeon or an interventional radiologist or a cardiologist. You need a hematologist and an emergency room physician. And there you have your team. You just start giving grand rounds, inform and increase awareness around your institution and outside of your institution, and then you will realize how many PEs will end up in your hands that are now just going into the bucket of lost cases.
Okay, thank you.
Okay, guys, enjoy the rest of your day. Again, it was a pleasure being with you for the morning.
Thanks again. Have fun in the rest of the conference.
Bye-bye.